Hello, everyone. My name is Olivia Gilchrist, and I'm a third-year public affairs and psychology double major.
Hello, my name is Isabella Reina, and I'm a third year public affairs and communications double major. We serve as undergraduate student researchers at the UCLA Pritzker Center for Strengthening Children and Families. And today we will be presenting our project, Understanding Adverse Childhood Experiences of Youth Living in the Antelope Valley. The UCLA Pritzker Center also acknowledges our presence on the traditional, ancestral, and unceded territory of the Gabrielino Tonga peoples. The Antelope Valley, also referred to as the AB, is a geographically isolated region of Los Angeles County, whose residents face substantial health disparities compared to other Los Angeles communities. The AB's unique combination of high need and limited resources make data-informed, targeted interventions critical for reducing the impact of adverse childhood experiences, or ACEs, and toxic stress. Data on the prevalence of ACEs in the Antelope Valley is limited and is often extrapolated from larger Los Angeles county-wide data. Therefore, our team is engaged in a collaboration project with ACEs LA to better understand the need of the Antelope Valley community by analyzing ACEs screeners and electronic health record narratives.
Adverse childhood experiences, or ACEs, are potentially traumatic life events that an individual experiences before age 18. ACEs are linked to poor health outcomes in both children and adults, including chronic diseases and serious mental health issues. They are especially common in economically disadvantaged regions and communities of color, and are classically divided into categories of abuse, neglect, and household dysfunction.
We are two undergraduate students among the 5 research assistants who conducted a retrospective chart review of 2,743 pediatric patients with a zip code in the Antelope Valley who had completed an ACE screener at an LA County Department of Health Services, or DHS, pediatric clinic between May 5th, 2020 and May 30th, 2024. DHS utilizes the PEARLS tool. Part 1 of the screener typically includes 10 adversities identified in adverse childhood experience screens, while Part 2 incorporates 7 additional health impacting adversities. Upon completion of the screener at a primary care appointment, the provider charted the score under the visit's date. In the case of duplicate screening, in which a patient had been screened more than once, the most recent or the highest scoring screen was included in review and other screens were omitted.
For each chart, research assistants first recorded the provider's documented ACE screener results and PEARLS responses for each ACE. The charts were then filtered to include clinical documentation from up to 3 years before and 6 months after the date of screening, spanning 42 months total. During the chart review process, research assistants identified and recorded any adverse childhood experiences documented in the patient's charts.
The research assistants also noted any ambiguities in documentation and brought questions to weekly research team meetings led by a DHS internal medicine and pediatrics clinician with extensive experience administering the PEARLS tool. She consulted with other providers and ACEs LA associates as needed when provider notes were unclear. Through these conversations, the chart review protocol evolved to account for nuances in inpatient experiences and provider documentation to ensure consistent data collection among research assistants.
The data collection process resulted in frequencies of adversities via the PEARLS tool and of adversities identified in clinical documentation. Our goal in this project was to understand what types of ACEs impact this community, as well as ACE disclosure patterns. Our findings indicate parental substance use, mental health, and incarceration were frequently identified in clinical documentation, but not disclosed on the screening tool in some cases.
Parental incarceration was identified in 157 charts, but only reported on the PEARLS tool 127 times. Parental mental health issues were identified 334 times during chart review, but only reported on the PEARLS tool 223 times. Parental substance use was identified in 268 charts during review, but only reported on the PEARLS tool 134 times. This adversity had the largest difference between the number of occurrences reported on the PEARLS tool and revealed in chart review.
There are many possible reasons a family may disclose household challenges or childhood adversity in clinical care, but not on a screening tool. Based on our research team's experience reviewing the medical charts, We believe some of these reasons could include, but are not limited to, differences in interpretation of screening questions and wording, nuances in the definition of certain adversities, questions in who qualifies as a caregiver, or trust in a provider that facilitates disclosure of ACEs not captured on the screening tool. A respondent might not respond yes on the PEARLS tool due to nuances in the definition of certain adversities or because they do not personally identify with the adversities. They may also interpret the screening question in a different way. Defining any adversity is individualized. For example, what is considered a mental health issue by one person may not be considered a mental health issue by another individual. Moreover, the time and duration of some adversities complicates how they are reported.
It may also be challenging for respondents to distinguish whether or not an adult in the household qualifies as a biological parent or caregiver, and therefore whether or not they should be taken into consideration while filling out the PEARLS tool. For example, a family may live in a joint household with multiple generations and family members. This can complicate reporting of ACEs. Are all adults in the household considered caregivers or just the primary parental figures? These questions are also questions that individuals may struggle with while filling out the PEARLS tool.
Finally, additional adversities might be identified in chart review compared to the screening tool due to trust built between the provider and respondent, leading to increased disclosure in clinical conversations. Current workflows at DHS clinics involve using a paper copy of the ACE screener given at the time of clinic check-in. A paper screener in the waiting room requesting disclosure of sensitive topics could feel impersonal to some respondents. During a face-to-face visit, on the other hand, the clinician can build a relationship with the respondent and cultivate a compassionate environment. In these settings, during relational conversations, patients and/or caregivers may feel more comfortable with a provider they know and trust. Using the paper screening tool requires thoughtful introduction and framing from the care team so families better understand the purpose behind screening for ACEs and what the information will be used for.
We know the PEARLS tool cannot tell the full story of a child's experiences. While it is a useful tool for quickly identifying a child's risk for cumulative trauma, our study shows that families may sometimes be experiencing adversities beyond what's reported on the PEARLS tool. Our study highlights the importance of ACE screening being only a first step of a larger ongoing conversation with families about challenges they may face and supports they may need. Additionally, it's important to acknowledge and respect why a family might not choose to document certain adversities and meet families where they're at, allowing them to share information when they're ready and in a way in which they feel safe and comfortable.
Despite the adversities that some children experience, youth in the Antelope Valley are resilient. One open-ended question on the PEARLS tool asks, what are your child's strengths? Our team is now focused on sharing our findings with both clinical providers and community-based organizations in the Antelope Valley. Among healthcare professionals, we are highlighting the importance of clinical documentation procedures to facilitate service continuity and promote trauma-informed care among all providers the patient may encounter. Thorough documentation also supports service linkage and follow-up efforts to comprehensively address trauma.
Among community-based organizations, we aim to use this research to propel cross-organization collaboration and service provision. We are also seeking to add to our comprehensive list of resources and supports in the Antelope Valley, so healthcare providers can refer to any available service that would benefit a child or family.
Lastly, we hope to conduct additional analyses to further illuminate adverse childhood experiences of children in the Antelope Valley and better understand patterns and trends in ACE screening disclosures to inform provider training and other workflows for ACE screening.
We'd like to express our thanks to the UCLA Pritzker Center and our academic supervisors, Dr. Lisa Gantz, Dr. Ivy Zakaya, Taylor Dudley, and Dr. Audra Langley. Second, we'd like to express our gratitude to the ACES LA team and our other academic partners, including Dr. Amy Shikarchi, Brittany Hun, Mia Meza, Nina Thompson, Jamie Ruiz, Bryn Burrows, and Celia Draycott. We hope this work encourages future efforts to identify and provide services to youth experiencing compound trauma and cumulative adversity, particularly in the Antelope Valley. Thank you.